now to my actual presentation on something which is very near and dear to my heart, which is the upcoming randomized control Unload-ECMO trial. And I'd like to guide you through not only the design of the trial, but some key decisions we made, and I'm very looking forward to what your opinions are on these. So these are, again, my conflicts of interest, haven't changed since. So, as stated before, VA-ECMO provides sufficient circulatory support in cardiogenic shock, but also increases afterload. And I think this is nicely visualized here. We put some contrast dye into the ECMO, and you see that it actually pumps against the heart, and this is something which you know is not good. And I also have shown this before. We tried to reverse this by putting in an impeller on top of ECMO, and in a previous trial, which is retrospective but propensity score matched data, have shown that this is associated with lower mortality. So this kind of laid the ground, the baseline for our work, which is now to start this randomized control trial. Unfortunately, we also saw that this approach was associated with more bleedings, more ischemics, and this is something which comes a bit natural to mind. If you have two devices instead of one, you might have more complications. So this is something to keep in mind for an aspect of the trial which is presented later. So we kind of said, okay, there is some rationale to do this in clinical practice. There's also risk to it, and to further evaluate this, we do need a randomized control trial, which is the prospective controlled Unload-ECMO trial. And our central hypothesis is that indeed in patients with severe cardiogenic shock, the addition of an impeller for active LV unloading on top of ECMO will improve 30-day mortality, will increase 30-day survival by providing this active LV unloading. And what we basically plan to do is to assess patients with severe cardiogenic shock due to severe left ventricular dysfunction. We'll then obviously check in and exclusion criteria, which I present later, obtain informed consent, and then randomize patients to one of two groups. And one would be the interventional arm. So these patients would be treated with an ECMO and an impeller. And the control arm would be patients being treated with an ECMO alone. And this trial is actually powered at the moment for 198 patients, so 99 per group. This is based on a power analysis which was done on the circulation paper I showed previously. And to confirm or to reassure this, we will plan on doing an interim analysis after enrollment of 75% of the patients, so 148. This will be a blinded interim analysis. We will basically only check for the mortality events, and then might increase the sample size up to 360 patients or stop the trial when we have sufficient endpoints there. And the primary endpoint for this trial will be 30-day mortality, or time to death from any cause within 30 days after randomization, although the overall trial will go on for per patient for a total of 12 months, and we will check other secondary endpoints such as 6-month and 12-month survival, heart failure hospitalization, change in LV, EF, and obviously the incidence of complications from LV thrombus, pulmonary edema to bleedings and ischemic complications, and the need for dialysis and strokes. So the first thing I would like to discuss with you here are the enrollment criteria. So the first, I think most of the lines will be very familiar. So we enroll a shock population, which we then thought should be more of a severe shock population. So we have a higher lactate of 5 as a comparison, ECLS shock and also Euroshock. The ECLS shock is almost completed, Euroshock is now stopped, have 3 and 3.5 millimoles per liter as the cutoff. So we opted to go for a bit higher target, as this is a trial which tests 2 against 1 interventions, and we thought it at the first step might be more reasonable to start in a cohort with severe cardiogenic shock. We also opted to allow pre-existing ECMO therapy, but only up to a total of 6 hours. This was basically done after, so we will enroll in approximately 10 to 15 centers, and after talking to the centers, we decided that giving this bit of a cushion might facilitate enrollment by a lot, while still not being hazardous to the patients, as we expect this to be a rather short time frame, which allows to, for example, implant an ECMO, then transfer a patient, then randomize in the trial, while not having too much of a window for this year. Other enrollment or inclusion-exclusion criteria, I think, come quite typical. So we need to have the other two components of shock, low blood pressure or need for catecholamines. We need signs of impaired end organ perfusion. And we also exclude atypical types of cardiogenic shocks. So, for example, shock due to acute rejection in heart transplant recipients, obstructive shock. So we do not want a patient with a fulminant LAE or pulmonary embolism in the trial. We want to limit this to left-sided cardiogenic shock. And we also opted to exclude post-cardiotomy shock because the mechanism behind this is just so different. Another thing which we did, we left the resuscitation window a bit more open. We were a bit less restrictive than in other trials. This was because we anticipate a certain amount of eCPR patients to be in there, and 60 minutes is something which allows for a good eCPR to be in there. But for someone who is on long chest compression and then arrives in the cath lab, this patient will most likely not be within the 60-minute time frames and then not be in the trial. So we try to match the criteria to a population we expect to be in this, and we expect to be okay to be in this. So, and I want to talk about some key features. What you did not see in the enrollment or criteria was anything referring to the presence of or absence of acute myocardial infarction. So basically, we decided that we would like to have the anterior wall STEMI in the trial as much as we would like to have the patient with a severe heart failure decompensation to be in the trial. I might not say acute decompensated heart failure anymore, as I learned before. And this was done because in the study I showed before, we didn't see any interaction between the cause of cardiogenic shock and the association between ECMO use and lower mortality. And also in unpublished data from, so this is basically on the left, a Kaplan-Meier curve is from a registry, which is only on patients with non-ischemic cardiogenic shock, so only patients with heart failure-related cardiogenic shock then being treated either with or without MCS, and in this population we also see lower mortality with MCS use. So this kind of prompted us to not limit the trial to AMI patients, but to be open to both populations. Another key feature is, and this should be 2 and not 3, I don't know why I jumped, so I might have problems with math, or it's the jet lag. And another key feature is the higher lactate threshold, and I told that to you before, so we use 5 instead of 3, or for example 2, which was used in the IVB shock trial. And we did this because in previous studies done together with Jack Jensen, we saw a significant increase, like a jump in mortality when lactate is above 5 across all SKY stages. And we wanted to target a high-risk population with this trial. And I think if this is successful, we can always go lower and always think about ways to expand this. But we thought the first step should be in this high-risk population. So we use a lactate cutoff of 5. And there's number 2. The key feature 2 is that the trial by itself, and that's not only the criteria which limits the enrollment of patients with pre-existing ECMO treatment to 6 hours, but also the trial will have dedicated SOPs, dedicated standard operating procedures, which will encourage the early implantation of an impeller, and preferably impeller before ECMO. And this is based on data which until yesterday was unpublished, and since yesterday is accepted and will soon be published, fortunately, where we could show that the earlier the impeller is implanted in relation to the ECMO. This is a spline chart, and basically the left part of it, the lower the hazard ratio we observe for 30-day mortality. And the more the impeller is implanted after the ECMO, and that's everything you see to the right, we have an almost linear increase between the association with 30-day mortality. So we want to urge and encourage the investigators to implant the impaler as early as possible. And also this SOP will also feature aspects to the whole journey of the patient. Will also encourage the investigators to explant the ECMO before the impaler. There will be certain protocols for weaning for both devices, not also for the technical part and not also only for the sequence of weaning. And another part is, and I've shown that before, that one issue we have in the obvious Achilles heel is complications. If we are terrible at putting in the ECMO and the impeller, and we are puncturing at the wrong places, and if we do the cannulation quite badly, then we will obviously have bleedings and we will have ischemia. So we will have certain procedures in place, and that will encourage the use of ultrasound-guided access, will encourage the use of micro-puncture sets, and also the application of an angiography before the devices are implanted, because we firmly believe that the 2 to 3 minutes which are additionally spent on preparing the access, they have a such high-fold kickback later via decreasing the risk of complication. I think this is something where, a bit like in the DTO STEMI trial, where some minutes in the early window of these patients which are well spent on preparing the access, on avoiding complications, and it might be more important to have that than to be a bit more faster with the reperfusion. So this is something which we will encourage by SOPs. Something which is missing and which we might discuss, we do not have any criteria for LV dysfunction. We say that the shock should be to severe LV dysfunction. So it should be a disease which incorporates the left ventricle. This is something we want to target. And we had a lot of discussion about this and then decided against to use an objective criterion, because in the end we felt that there is none which you can firmly back. We talked about using LV-EDP, EF, LV-EDD, and all the other acronyms that there are, but we didn't have any data which would back up one. And there are some protocols in place to assess this in the trial, and we hope to learn more about this. But at the moment, we do not feel that we can convincingly go somewhere and say, okay, you need to enroll this kind of patients, especially, or stratify for this. So there's no strict criteria for LV dysfunction. So all left-sided shock is welcome for the trial. And yeah, that's basically the presentation of the trial. I'm happy to take